What is angina pectoris? Cardiovascular disease is the leading cause of death in the United States for men and women of all racial and ethnic groups. Angina pectoris is a clinical syndrome usually characterized by episodes of paroxysms of pain or pressure in the anterior chest. The cause is insufficiency coronary blood flow, resulting in a decreased oxygen supply when there is increased myocardial demand for oxygen in response to physical exertion or emotional stress. There are five classifications or types of angina. Number one, stable angina, where there is predictable and consistent pain that occurs on exertion and it is relieved by rest or by nitroglycerin. Unstable angina, the symptoms increase in frequency and severity and may not be relieved with rest or nitroglycerin. Intractable or refractory angina, there is severe incapacitating chest pain. Variant angina, there is pain at rest with reversible ST segment elevation and thought to be caused by coronary artery vasospasm. Silent ischemia, there is objective evidence of ischemia but the patient reports no pain. Pathophysiology of angina. Angina is usually caused by atherosclerotic disease. Almost invariably, angina is associated with significant obstruction of at least one major coronary artery. Oxygen demands not met. Normally, the myocardium extracts a large amount of oxygen from the coronary circulation to meet its continuous demands. Increased demand. When there is an increase in demand, flow through the coronary arteries needs to be increased. Ischemia. When there is a blockage in the coronary artery, flow cannot be increased and ischemia results which may lead to necrosis or myocardial infarction. The causes of angina pectoris. There are several factors which are associated with angina. Physical exertion. This can precipitate an attack by increasing myocardial oxygen demand. Exposure to cold. This can cause vasoconstriction and elevated blood pressure with increased oxygen demand. Eating a heavy meal. A heavy meal increases the blood flow to the mesenteric area for digestion, thereby reducing the blood supply available to the heart muscle. In a severely compromised heart, shunting of the blood for digestion can be sufficient to induce anginal pain. Stress. Stress causes the release of catecholamines, which increase blood pressure, heart rate, and myocardial workload. Clinical manifestations. The severity of symptoms of angina is based on the magnitude of the precipitating activity and its effect on activities of daily living. Chest pain. The pain is often felt deep in the chest behind the sternum and may radiate to the neck, jaw, and shoulders. Numbness, a feeling of weakness or numbness in the arms, wrists, and hands. Shortness of breath. An increase in oxygen demand could cause shortness of breath. Pallor. Inadequate blood supply to peripheral tissues cause pallor. Gerontological considerations. Here's what you need to know when caring for geriatric patients with angina pectoris. The elderly person with angina may not exhibit the typical pain profile because of the diminished responses of neurotransmitters that occurs with aging. Often, the presenting symptom in the elderly person is dyspnea. Sometimes there are no symptoms, which is called as silent CAD, making recognition and diagnosis a clinical challenge. Elderly patients should be encouraged to recognize their chest pain-like symptoms, example weakness, as an indication that they should rest or take prescribed medications. The complications. Myocardial infarction is the end result of angina pectoris if left untreated. Cardiac arrest. The heart pumps more and more blood to compensate the decreased oxygen supply, and the cardiac muscle would ultimately fail, leading to cardiac arrest. Cardiogenic shock. Myocardial infarction also predisposes the patient to cardiogenic shock. Assessment and diagnostic findings. Echocardiogram. 24 hours ECG monitoring by Holter, exercise or pharmacological stress electrocardiography, cardiac enzymes like AST, CPK, CK, and CKMB, LDH and isoenzymes LD1, LD2, chest X-ray, PCO2, potassium and myocardial lactate, serum lipids, which includes total lipids, lipoprotein, electrophoresis, and isoenzymes cholesterols like HDL, LDL, VLDL, triglycerides, phospholipids may be elevated, which is again CAD risk factor. Echocardiogram may reveal the abnormal valvular action as the cause of chest pain. Nuclear imaging studies, rest or stress scan, thallium 201, ischemic regions appear as areas of decreased thallium uptake. MUGA elevates specific and general ventricle performance, regional wall motion, and ejection fraction. Cardiac catheterization with angiography, and ergonovin, which is ergotrate injection. These are the assessment and diagnostic methods to find angina pectoris. Medical management. The objectives of the medical management of angina are to increase the oxygen demand of the myocardium and to increase the oxygen supply. Oxygen therapy. Oxygen therapy is usually initiated at the onset of chest pain in an attempt to increase the amount of oxygen delivered to the myocardium and reduce the pain. The various pharmacological therapy includes nitroglycerin, which gives long-term and short-term reduction of myocardial oxygen consumption through selective vasodilation within 3 minutes. Beta blockers reduces the myocardial oxygen consumption by blocking beta-adrenergic stimulation of the heart. Calcium channel blockers have negative inotropic effects. Antiplatelet medications to prevent platelet aggregation and anticoagulants to prevent thrombus formation. These are some of the pharmacological therapy which is used to treat angina pectoris. Thanks for watching. If the contents of this video are informative and useful, subscribe the channel, like the video, share this with your friends and colleagues. Comments are welcome for further updates. Thank you.